Welcome to TCCC-Plus Day 2, Module 11, Pain and Nausea. This module covers safe analgesia, the three kinds of pain, the oral non-opioid backbone, and opioid and ketamine safety with naloxone. Of course, we treat pain to relieve suffering, but also because pain itself can cause physical harm. It raises the heart rate, makes breathing more shallow, causes agitation and exhaustion, and stops a casualty cooperating, and slows wound healing. But there is an order of priorities the doctrine is firm about, and keeping the casualty alive comes before any painkiller. Do not give pain medicine if it delays something more urgent, like bleeding control. Second, protect their physiology. Do not give a drug that drops blood pressure or slows breathing to a casualty who is in shock or struggling to breathe, or who is heading that way. Only when emergent threats are handled do you treat the pain itself. Again, pain relief never comes before hemorrhage control or perfusion. Assessing pain is generally quite easy. Ask where it hurts, how bad, and whether movement or touch makes it worse. Watch for grimacing, guarding, agitation. And a point that matters, don't assume that sudden agitation is caused by pain. It should be a diagnosis of exclusion. Among the most common causes of agitation may be untreated pain, but low oxygen, low blood pressure, and low blood sugar are all common and much more dangerous. So before you reach for more sedating painkillers, check whether the casualty is hypoxic, bleeding, or crashing. Sedating a hypoxic casualty hides the very thing that is killing them and may kill them faster. In general, we can think of pain as three different types. Background pain is the pain at rest from the injury. Keep them comfortable without harming breathing or blood pressure. Breakthrough pain is pain upon movement or handling or other episodic, worsened pain. Treat as needed, and if it is frequent or happening at rest, increase the base dose of medication or frequency within safe limits. Procedural is pain you are about to cause. Anticipate it and plan for it before you start doing something that may cause pain. Remember that there are three things you cannot easily take back: blood when lost, heat when lost, medication when given, and time when lost. You can always give more drugs, but you cannot take it back. So if you are delegated the responsibility for pain relief drugs, go slow, use lower doses than you think may be necessary, titrate to effect, and redose rather than overdose. That patience is what prevents the wild swing between an over-sedated casualty who has stopped breathing and an undertreated one who is agitated and fighting you. Though this class doesn't focus on lots of different types of pain relief, we think it is useful for you to know they exist, in case you come into contact with them at some point. To be clear about scope, these are listed so you recognise them and understand what a medic is giving, not so you can give them. Nothing beyond your own protocol is yours to administer without specific training and delegation. Here's an overview of the classes in the pack and the catch on each. Paracetamol is the safe base and has no effect on breathing, should always be the foundation of pain relief. The anti-inflammatory dexketoprofen or meloxicam is held in shock, bleeding, or kidney risk. Nefopam is a central-acting, non-opioid and non-anti-inflammatory drug that should be avoided in head injuries. The opioids slow breathing and drop blood pressure. Ketamine is dissociative, causing pain relief, and at higher doses, sedation. The antiemetic ondansetron covers nausea from pain or the drugs. At this level, the backbone of pain relief is oral, and you build it from drugs that work in different ways. Paracetamol, 1 gram up to 4 times a day, is the safe base. It does not meaningfully affect bleeding, blood pressure, kidneys, or breathing. However, do not exceed 4 grams a day. You can also add 1 anti-inflammatory, not 2, either meloxicam, 15 milligrams once a day, or a faster one like dexketoprofen if given by injection, but never both because they both work in similar ways affecting the kidneys, gut, and may increase bleeding risk. Avoid the anti-inflammatory altogether in active major bleeding, shock, dehydration, or kidney problems. Nefopam is a centrally acting painkiller that is neither an opioid nor an anti-inflammatory, largely specific to Ukraine. It has its own cautions, which we will come to later, and for moderate to severe pain, a long-acting oral opioid like OxyContin 10 milligrams twice a day is useful for long holds, but can cause sedation, slow breathing, and drop blood pressure, so avoid it if consciousness is reduced, in shock, or with already slow breathing. We build the analgesia stair or pyramid from the bottom. Paracetamol as the base, and anti-inflammatory and nefapam stacked on top, as these do not slow breathing or usually thin the blood. Opioids and ketamine sit above, by protocol only. The trap is reaching for the strong drugs first. Again, you can always give more, you cannot take it back. In trauma, this combination is often preferred pre-hospital because the non-opioids avoid the very problems the strong drugs cause. Paracetamol and nefapam do not slow breathing, do not thin the blood, and do not stress the kidneys or the gut, the opposite profile to opioids and anti-inflammatories. In the cold, there is a second reason. Opioids, ketamine, and benzodiazepines all switch off shivering, the casualty's own heat source, while paracetamol and nefapam leave it running. A non-opioid backbone keeps the casualty breathing, clotting, and shivering, three things you badly want in a long, cold hold. When oral pain relief is not enough, the step beyond it at this level is intramuscular ketamine, and it is by protocol or telemedicine only. 100 milligrams, repeated after 30 minutes if pain persists. Do not chase a specific number. Stop when the pain is tolerable or the eyes start their slow rhythmic drift, an eye movement called nystagmus that tells you the drug is working. It can sedate and sometimes may cause a frightening emergence reaction. Esketamine, 14 or 28 milligrams intranasally, is also an option. Everything other than this and the intravenous routes sit far above this course. The point is that oral is the backbone, and the injected drug is the exception you give by the book, by protocol, or telemedicine. The single most important safety point when you carry more than one of these drugs is that they together may be more potent than alone. Ketamine, opioids, and benzodiazepines given together do not add up, they multiply. The effect of two together is far greater than either alone. So if a casualty has already had one, give markedly less of the next, not a full dose. Most dangerous oversedations come from stacking different drugs. As mentioned, strong analgesia can suppress breathing and lower blood pressure, so monitor alertness, breathing rate, the airway, and nausea. Go slow, use lower doses, titrate and redose rather than overdose, and keep naloxone available whenever opioids are given. It reverses opioid-induced breathing suppression. Give small amounts and repeat as needed, enough to bring the breathing back without wiping out the pain relief entirely. Make sure naloxone, the antidote to opioids, is actually in your kit before you give the opioid, as this mistake has been made before and you don't have the naloxone available when you actually need it. Dosing of naloxone in severe overdose is 0.4 milligrams IV or IM, but should usually be dosed by telemedicine. After opioids or ketamine, keep watching breathing and the airway. For nausea, which threatens the airway, because a vomiting casualty who cannot protect their airway is in danger, use the recovery position and ondansetron 4 milligrams up to 3 times a day. Ukrainian field practice often uses 8 milligrams. Follow your own protocol. Also, remember that good pain control reduces nausea on its own. 4 things to watch regarding our preferred medications, because every one of them has a catch. First, as mentioned, we should not stack 2 anti-inflammatories. Dexketoprofen on top of meloxicam isn't good for the kidneys, gut, and bleeding risk, so pick one. Second, nefapam lowers the seizure threshold, increasing the risk of seizures, so it is the wrong choice in a head injury or anyone prone to fits, and head injury is everywhere on this battlefield. It also speeds the heart and brings on sweating, which can look exactly like shock and muddy the trend you are watching. Third, ondansetron can disturb the heart rhythm, and that gets worse when the salts in the blood are off, which is exactly what happens after big transfusions, where calcium becomes too low. Fourth, nefapam and ondansetron together can fog the mind and stop the bladder emptying, confusion you do not want when you are tracking consciousness in a head injury, and a full bladder you will then have to manage on a long hold with a urinary catheter. So let's repeat reassessment regularly, after interventions, after moves, after changes in patient status, and at handover. For pain, the 5th question in reassessments, what am I going to do about it, includes redose, hold, or reverse. Reassess breathing and sedation after every dose, along with the pain score. Let's recap. None of this changes the rule. March before pain control. Oral backbone first. Other pain relief is given by protocol or telemedicine. Every drug documented with dose and time, then reassess. And don't give opioids without having naloxone available. Thanks for watching Module 11 of the TCCC-Plus course, Day 2, Pain and Nausea. Next up is Module 12, Infection and Antibiotics.